Hello, and welcome to the October 26th Virginia Opioid Abatement Authority Abatement Academy. My name is Jennifer Nelson, Virginia Institute of Government, Assistant Director for Membership and Engagement. The Virginia Institute of Government is the leadership development and community engagement arm of the Weldon Cooper Center for Public Service at the University of Virginia. Through our research, leadership development programs, and local government engagement initiatives, we continue to work toward our vision of good governance, equity, and resilience in every Virginia community. VIG offers leadership development through SEI and LEAD, local government equity clinics, certification for treasurers and commissioners of the revenue, and customized training programs. State agencies and local governments can access a range of consultation and support services to build more resilient organizations. We have a team of seasoned public sector leaders and subject matter experts ready and available to facilitate boards of supervisors, city and town councils, leadership teams, strategic planning retreats, and other related events. Today, VIG is glad to partner with the Opioid Abatement Authority for this Abatement Academy series. Just 2 more sessions in 2023, presented on November 9th and December 14th. A few housekeeping notes. This session is being recorded and will be posted on the Weldon Cooper Center for Public Service YouTube channel soon. If you have any questions, please type them in the chat and I will ask them for you. Thanks again for taking time to join us today for this Abatement Academy session. Now I'm happy to turn things over to Tony McDowell, the Authority's Executive Director. Tony?
Thank you, Jennifer. It's really my pleasure today to introduce our speaker. Monique Runge from the McShin Foundation started her recovery journey at McShin in early 2021. She then became its peer community and program liaison, focusing on both interacting with participants in the Women's Intensive Program and assisting with special events and social media. She's now the Community Engagement Coordinator, responsible for representing McShin at events and advocacy spaces in the community, including the Virginia Recovery Advocacy Project. She is a certified peer recovery specialist, and she hopes to impact the recovery community by expanding accessibility, promoting diversity, and empowering young women to find a better way of life in recovery. And so with that, I'm very happy to turn it over to Monique for today's presentation.
Thank you, Tony and Jennifer, and thank you for anyone that is tuning in. Like he said, my name is Monique Runge. I am a certified peer recovery specialist here at the McShin Foundation and also the Community Engagement Coordinator. I'm very excited to be talking about this topic with you all today. So we will be talking about serving diverse individuals in a peer-led recovery community organization. And just a little background as to why this is so important to me and why I'm so passionate about these issues is I am a Black woman in America, but I am also biracial. So I do identify as a Black woman because that is how I have been treated in society. But I am half white, half Black. My father is in recovery, long-term recovery of 31 years. And on my mother's side, we also had a lot of substance use disorder going on. And I had the privilege of being able to see the different perspectives from 2 different cultures and how they were treated, what stigma was brought to them, and even their reluctance or excitement on how to ask for help. So I have seen a little bit of both sides. And now working in this field, I hope to help expand that accessibility to others. So today we're going to be going over some very simple definitions, some different primary goals, and we're also going to go across some background and statistics on, to actually validate those. And then we're going to go over some areas of growth for peers, some ethics concerning this, and discussion, and we'll open it up for Q&A at the end. So, what is culture? So Merriam-Webster defines culture as the customary beliefs, social forms, and material traits of a racial, religious, or social group. So this also means the characteristic features of everyday existence. such as diversions or way of life shared by people in a place or time. So specifically, we're going to be talking about race as a culture within this presentation. But of course, culture can mean a number of these things. This also means that you can interpret the same thing very differently from someone else, depending on your culture and how you were raised, and what you were raised around. So, what is diversity and equity, and how does your organization stand up in regards to these? So, a simple definition of diversity is the presence of differences within any given setting. So, in your workplace, that can mean differences in race, ethnicity, gender identity, sexual orientation, age, socioeconomic class. It can also refer to differences in physical abilities, veteran status, whether or not you have children. All of those are different components of diversity. And so for equity, now equity gets confused a lot with equality. And we will have a slide that kind of shows the difference between equality and equity. So equity is the process of ensuring that practices and programs are impartial, fair, and provide equal possible outcomes for every individual. So once again, how do we ensure equity? That means we're going to try to make sure that every individual, we look at what barrier they have and how do we overcome that to ensure that that individual has the same opportunity for an outcome as someone that might not have that barrier. So as far as examples of diversity in our workplace, I know for us here at McShin, we have people of different races, we have different genders. We do not have any different gender identities yet. We do have people of different sexual orientation, age, a ton of different socioeconomical classes. So for us, I feel like that's a very big benefit for us because we're able to have different staff members relate to different participants that come in. We do not call our participants clients, we call them participants. And that way they feel a little bit safer to know that they can be open and honest with us. All right, so what is the difference between equality, equity, and justice? So the first image is going to be what the reality of it is, right? One person automatically has a lot more than they need, the basic necessities. One other person has kind of what they need, but not in excess like the first person, right? And then you've got the guy that looks like he's in the hole. He has a lot more barriers to overcome because of his environment. And he's got a huge disparity there, right? So equality, and what people get mixed up with equality and equity. So equality is to assume that everybody needs the same exact opportunity or the same assistance, right? So we assume that everyone's exactly the same. No one has their own identity, right? And we give them all one box. Now, as you can see, that works for 2 out of the 3 people. One guy, he still has, pretty good view. The second guy, he's at the same thing as where he started at. And the third guy, with that same help, he still can't see. Now, the third image would be equity. So equity, everyone gets the support they need. And we have to recognize that with individuals. Now, the first guy, he might not need any boxes to stand on. The second guy, he was fine with 1 box, but that third guy needed 2 boxes. And that is absolutely okay. That does not make that third guy any less important or means that we value him any less. So, and my favorite piece, of course, is always going to be justice. I know we're not talking about all of DEIJ, but I love justice. That's the end goal to me. Justice means that we get rid of the barrier in general. Like we go to the system and we knock it all down and say, why is there even a fence here? Everyone deserves to see the game, and this isn't fair. That's kind of what we want to get to within the recovery community. Everyone deserves access to treatment. Everyone deserves the opportunity to recover. your socioeconomic background should have nothing to do with your access to treatment, in my personal opinion. So, what is cultural competency and why should we practice it in a peer-led organization? So, the American Psychological Association has loosely defined cultural competency as the ability to understand, appreciate, and interact with people from different cultures or belief systems from your own. So, why is it important for us to strive for cultural competency in our behavioral health professions? Well, every human that seeks help comes with their own unique cultural identity, which molds their values, beliefs, and practices. So we have to keep that in mind. We don't want to smother someone's personal identity just to allow them to have space or access to our services. We still want people to be fully themselves, authentic, just as peers were able to be authentic in our lived experience. So some of these goals that we're going to try to go over, we're going to try to discuss how some of our bias, power, or privilege can affect this therapeutic relationship that we have. Discuss ways to learn more about someone's cultural identity while in our roles. Discuss how stereotypes and microaggressions can affect someone's recovery experience. Explain how culture and stigma can influence help-seeking behaviors. Describe how communication styles can differ across cultures, and identify strategies to reduce bias during the assessment and recovery planning portions. So I wanted to start this out. It's just a quick 3.5-minute video, and it is narrated by the rapper Jay-Z, and it is about the history of the war on drugs. Now, the reason why I wanted to show this is because I know that this can sometimes be a tough subject to talk about, especially when working in this field, we put so much work and energy and love into our work that sometimes we don't see our bias or we don't see the systematic barriers that have been set in place for Black and brown individuals in America. So this just kind of shows the history of what the war on drugs has done to the Black and brown communities in America, and it kind of leads up to current dates. So.
In 1986, when I was coming of age, Ronald Reagan doubled down on the war on drugs that had been started by Richard Nixon in 1971. Drugs were bad, fried your brain, and drug dealers were monsters. The sole reason neighborhoods and major cities were failing. No one wanted to talk about Reaganomics and the ending of social safety nets, the defunding of schools and the loss of jobs in cities across America. Young men like me who hustled became the sole villain, and drug addicts lacked moral fortitude. In the 1990s, incarceration rates in the US blew up. Today, we imprison more people than any other country in the world: China, Russia, Iran, Cuba. All countries we consider autocratic and repressive. Yeah, more than them. Judges' hands were tied by tough on crime laws, and they were forced to hand out mandatory life sentences for simple possession and low-level drug sales. My home state of New York started this with Rockefeller laws. Then the feds made distinctions between people who sold powder cocaine and crack cocaine, even though they were the same drug. Only difference is how you take it. And even though white people used and sold crack more than black people, somehow it was black people who went to prison. The media ignored actual data to this day. Crack is still talked about as a black problem. The NYPD raided our Brooklyn neighborhoods while Manhattan bankers openly used coke with impunity. The war on drugs exploded the US prison population disproportionately, locking away Black and Latinos. Our prison population grew more than 900%. When the war on drugs began in 1971, our prison population was 200,000. Today it is over 2 million. Long after the crack era ended, we continued our war on drugs. There were more than 1.5 million drug arrests in 2014. More than 80% were for possession only. Almost half were for marijuana. People are finally talking about treating addiction to harder drugs as a health crisis. but there's no compassionate language about drug dealers. Unless, of course, we're talking about places like Colorado, whose state economy got a huge boost by the above ground marijuana industry. A few states south in Louisiana is still handing out mandatory sentences for people who sell weed. Despite a booming and celebrated 50 billion legal marijuana industry, most states still disproportionately hand out mandatory sentences to Black and Latinos with drug cases. If you're entrepreneurial and live in one of the many states that are passing legalized laws, you may still face barriers participating in the above ground economy. Venture capitalists migrate to these states to open multi-billion-dollar operations, but former felons can't open a dispensary. Lots of times those felonies were drug charges, caught by poor people who sold drugs for a living, but are now prohibited from participating in one of the fastest growing economies. Got it? In states like New York, where holding marijuana is no longer grounds for arrest, police issue possession citations in Black and Latino neighborhoods at a far higher rate than other neighborhoods. Kids in Crown Heights are constantly stopped and ticketed for trees. Kids at dorms in Columbia, where rates of marijuana use are equal to or worse than those in the hood, are never targeted or ticketed. Rates of drug use are as high as they were when Nixon declared this so-called war in 1971. 45 years later, it's time to rethink our policies and laws. The war on drugs is an epic fail.
So with that video, I do want to say, right, how a lot of the help-seeking behaviors differ between different cultures. So when we talk about serving diverse populations, we have to look at and know that within the Black and Brown communities, asking for help is not always seen as strong. And I've seen it firsthand within my own family. You know, on my white side, it was like celebrated, like, yes, you are asking for help. That's exactly what you need. Whereas, you know, on my Black side, it was like, well, why not? Let's try to go to Bible study, or you don't have any mental health issues. And I know it's like that a lot with the Hispanic community as well. So you already have this stigma trying to serve this population, and trying to be like, wow, you have to really look at it like, wow, they took a huge step, which we all take a huge step when we come into recovery. But it's just that extra stigma hurdle that specifically those two cultures have to battle just to get to the door, right? And then we look at what the crack cocaine epidemic did. We didn't even call it an epidemic before. It was just the crack era, right? And then we have to look at how society treats the opioid epidemic. There has been an issue that's ravaged generations of the Black and Brown community. But when did it become an epidemic? It became an epidemic when it started to touch those suburbs, when it started to touch demographics that they thought, we don't have that issue. So you're already working from, in this behavioral health profession, you're already coming from, you're kind of battling and starting from behind, because there might be that mistrust there already. And it has nothing to do with what you've done, but more of what society has put in the heads of Black and Latinos. So we're trying to overcome that. So with this, we're going to go through some statistics. So in 2020, SAMHSA reported that of individuals who need treatment for illicit substance use disorders, whites receive treatment 23.5% of the time. That's still not enough, right? While Black and Hispanic individuals receive treatment 18.6% and 17.6% of the time. While all of these numbers are entirely too low, we have to look at why is that lower within the Black and Hispanic community. So a determining factor for this is access to adequate health insurance. So 12 states still have not adopted the ADA's Medicaid expansion, right? So thankfully, Virginia, we're good there, right? 7 of which are in the Southeast, where the large majority of the Black US population lives. And so like we were talking about, a barrier that professionals must overcome is the distrust of medical and healthcare professionals that Black and Hispanic Americans have inherited. Like I said, we're trying to work against years and years of of brutality, of mistreatment, of discrimination. So we have to keep that in mind. Black older adults who are exploring recovery now, they're still struggling with the effects of the crack cocaine epidemic. So, I mean, this had devastating effects. I mean, there are large number of cities in America that still have not recovered, and a lot of them are in Black and Brown communities. So we need to understand that in our role. So in 2018, substance use disorder was the #1 health issue among Americans, yet only 18% of people that identified as needing help received it. So the gap was even greater in the Black and Hispanic communities. 90 and 92% still did not receive help. So a study of privately insured people, we also have to look at that. What does that entail, right? Showed us that Black and Brown patients were 70% less likely to receive buprenorphine prescriptions than their white non-Hispanic counterparts. Now, we know, working in this field, there are a ton of different pathways. There are a ton of different medicated assisted treatments. It's not just buprenorphine or bust, right? But this is a, evidence-based treatment that we have seen has worked. So why is that? This same study showed that Black and Brown patients were half as likely to obtain follow-up treatment after an overdose. Now, I'm going to repeat that. Black and Brown patients were half as likely to obtain follow-up treatment after an overdose. So when you look at that from a recovery and treatment standpoint, they were also 3.5 and 8.1 less likely to complete a treatment program as their white non-Hispanic counterparts. So where are we missing the mark? Where are we missing the mark? So areas of growth for peers. So we've talked about how SAMHSA reported that Black and Hispanics have substantially lower access to mental health and substance use treatment services, often end treatment services prematurely, and experience less culturally responsive care. In recent years, we know homelessness has gone skyrocketed, right, with this cost of living, COVID-19 displacement, gentrification, police brutality, and racism overall in the Black and Brown communities are all crises that are intertwined and adversely affect behavioral health in these communities. So we must also acknowledge our own pre-existing bias, right, and power and privilege while serving others. While I am part of the BIPOC community, Black, Indigenous, and people of color, I can say I have privilege, right? My parents moved us to the village of Midlothian in Virginia. It's a very affluent suburb. I went to a very good public school. I had a very good education. I had the opportunity to go to college. And these are all things that not everyone has. So while I have the experience, the lived experience of being a woman of color in this country, I also have to acknowledge my privilege. So I challenge, all of you as peers, we all have lived experience and all of our lived experience is different. To maybe just sit down and reflect sometimes and think about some of the privilege that maybe you've had growing up, and how that could affect your bias when you're trying to do these hands-on peer-to-peer services. And I'm always going to reiterate this. Sorry. It is the behavioral health professionals' duty to ensure equitable and culturally competent care to give those seeking help, regardless of their cultural background. It is our duty. For me, I feel as though empathy is the #1 benefit that people that receive services at recovery community organizations over treatment in clinical treatment facilities, we have empathy because we have the lived experience. That is the #1 benefit. We know that we can tell you how to get through certain things because we have gone through things similar. So if you are finding yourself unable to feel empathy for certain individuals, that's that moment when you really need to reflect on what is it. You know, that's the only way that we can be better as professionals. So once again, how do we grow? So ask your participants about their life's experiences. I mean, socioeconomic, discrimination, their values, their beliefs. This can be really uncomfortable sometimes. I know it can be uncomfortable. But this, if you just get over that little hurdle, imagine how uncomfortable that participant is trying to divulge this information to you, right? Especially serving these diverse populations. We are not used to opening up and talking about our feelings or talking about traumas, because we were always supposed to be strong and resilient, you know. So if you feel uncomfortable, imagine what they feel and just try to get over that hurdle, because that will give you insight to what their life really was like growing up. And also imperative formative beliefs and behaviors that might differ from yours or what you're usually exposed to. Have diverse representation at your job. I mean, this includes, like we talked about, race, gender identity, age, veteran status. Having representation from someone from a marginalized population that they can identify with, it gives them hope, especially in a peer-based organization, because there is nothing like, I remember when I came into recovery and I didn't really see a lot of people that looked like me. I was wondering, am I in the right place? Because when we look at media, the movies, there's not a lot of Black and brown representation of people that have the happy ending with substance use disorder. We're almost always portrayed as the drug dealer or as someone that suffers and struggles through their entire life, right? And we don't see they got help, so maybe I can get help, and maybe this isn't normal. So I can't tell you how amazing it was having that thought of, I don't really see anyone that looks like me. And Morris Baton was our director of was our men's program director. And I remember just walking into his office and I was like, I heard a voice, I heard the voice and I was like, man, okay, let me go see. And it meant everything to me that he was here, he was working there. So not only was he also a person in recovery, but he was still in recovery and actually working at this organization. That meant everything to me. So just imagine what representation could mean to someone from any of these diverse populations within your organization. How do we ensure equitable access for marginalized communities? So what we have found has been very helpful is having specific fundraising efforts or funding proposals that are specific, that also reserve specific access for these communities. Meaning, as an example, if we're doing a outreach grant in the city of Richmond, that also, we also have the funding for the outreaches, but we also are requesting funding for top tier programs for people within those marginalized communities, within that Gilpin court, within the Mosby court. I mean, that's where we're going to get it, because financially, that's a big barrier for a lot of people. They're intimidated. They might not even try to see if they can get help because they already know they don't have money. So does your organization have specific fundraising or funding proposals that include these diverse populations? Do you have bilingual staff available to make communication easier? I know that, there are numerous languages spoken in America, spoken in the state of Virginia, but I know that Spanish is the second language that's spoken besides English, as far as statistically. Do you have any bilingual staff? Do you have someone where they can, if someone, their first language isn't English, how do you serve them? Does your organization have representation in outreach spaces in these communities? Or does someone have to be in the know, right? So this is something that I've seen in the recovery community organization spaces. So when I go out to certain areas, right, some people have never heard of an RCO. They have no idea what it is. They just think, well, if I needed help, I thought I needed to pay $30,000 to go to a clinical treatment. I didn't know these type of places exist. And a lot of people that are in the recovery community, right, we're in the know. We know, oh, we know about this RCO or this RCO. Well, what about these communities where the access isn't there because there's no education on the resources that are available for those communities? That's what we're seeing a lot, is we're going into these communities and they have no idea that a lot of these resources are free or readily available. So does your organization have representation in those? And at the end during the Q&A, I hope to get some examples of what your organization's equity efforts are. Cultural competency, equity, and ethics. So benefits of using ethics while practicing cultural competency and ensuring equity. We always want to practice ethics, right? I mean, that's especially in peer-led organizations. We're already, facing scrutiny from, clinical people, or we're already facing scrutiny of, do people with lived experience have certain professionalism? So we always want to remain on top of our ethics. But some of the benefits of using the ethical values and practicing under the values of respect, acceptance, compassion, and authenticity is we try to erase any bias of individuals within your organization in order to practice cultural competency and operate from empathy, right? How do we do that? We do that by trainings, sensitivity trainings, DEIJ trainings. I mean, if we're able to do trainings on everything else, why can't we do trainings on how to treat people with respect from different cultures? Have a standard process for all assessments that have gone through an ethics committee for approval. And of course, expanding accessibility to marginalized populations that may not receive the same access to healthcare through mainstream treatment facilities. So examples of when ethics comes into play. All right. So let's say someone that speaks English as their second language, you have a participant and they feel very unheard. They seem disgruntled. They're starting to isolate. What do you do in that situation? Do you just treat them like they're isolating because they just don't feel like they fit in and everyone goes through that phase? Or are you really being culturally aware and saying, you know what, maybe this person needs a recovery coach session with one of our bilingual staff members? Let's say someone has described a discriminatory experience within your organization. Now that one can hurt, right? That one can really hurt because we want to feel like we're being genuine and trying to help every single individual, especially because we have the lived experience and we know what it's like to live in active addiction, right? What do you do? What is the process that your organization takes when someone does have that type of complaint? Does it go just straight to a program manager? Does it go all the way to the COO or CEO? Does it go to an ethics committee? What is your organization's process for that? How do you operate with that grievance? Let's say someone with different mannerisms is having trouble settling in. Now, remember at the beginning, we talked about culture, right? And what that meant and how different people have, it's a different diversion or everyday way of life. So I have a really good example of this. One time we had a participant that was Hispanic and for some reason kept getting called in, right? Because someone felt like she was being disrespectful. Now, what happened is our COO brought me into the situation, right? And was like, I just need some clarity and maybe some perspective. And my perspective was that person is Puerto Rican from Philadelphia and has been living on the streets. She's a little bit more animated, just like I'm a little bit more animated than some of my other coworkers. I speak with my hands, so I understand. Sometimes it comes off, it can be a little abrasive to people that don't know you. And once we talked about that, we were able to de-escalate the situation and be like, you know what? This person's actually not being disrespectful. They're actually really excited. They're actually really excited about their recovery journey. So what would your organization do when you have that? Does your organization use the participatory process? So we all know the benefits of using the participatory process, right? We want to involve the people that are the type of people that we're serving while trying to write our policies, while trying to figure out how to serve these populations. In my opinion, if you have questions about how to serve a specific population, especially within marginalized communities, simply ask someone from that community. Don't just guess because you might not have the perspective that they have. You might not have the same type of lived experience as they have. So always just involve someone from that community. So we use these processes to clarify program rules. We use them to develop and revise code of ethics. We use them to set policies and practices. We also have, we form ethics committees or work groups. I know for us at McShin, we have a DEI committee. We meet regularly to address ethical challenges, specifically concerning serving diverse populations, and periodic process in place for review, evaluation, and modification of program values, key practices, and code of ethics. Not everything stays the same all the time. We're learning that so much, right? Just like with language, it's forever changing. So do you have a periodic process of being like, what can we do? What can we add? What can we modify? All right, so the summary. While working in the behavioral health field, specifically in peer-led recovery community organizations, it is important for us as professionals to practice cultural competency in order to understand and recognize how economic, physical, socio-political forces, all of these things impact those from marginalized communities. This will ensure that people from different backgrounds have the same hope for a healthy future. And that would be it for my presentation. If there are any questions, I would love to answer them.
Thank you, Monique. Thank you for sharing this. I think one of the great things that you were saying was not only do we have to put these rules in place to be mindful of how people are in our community, but also revisit it, not just put it down on a piece of paper and put it on the shelf and saying DEI is done. Okay, let's move on, but to revisit it. So I think that's a great point. Thank you. Everyone, please share your questions for this subject matter expert while we have her. And let us also talk about, while I'm waiting for questions to come in, we have 2 more sessions in the Abatement Academy, November 9th and December 14th. And really excited to wrap up 2023 with the Abatement Academy. Tony, is there anything you want to add to?
Thanks, Jennifer. Well, first of all, thank you, Monique, for a great presentation. I think that's A lot of really good information there and really well presented. We appreciate you coming here as a guest speaker. Just as a reminder for everyone, we record these and post the recording on the website, and we'll also post the PDF of the presentation. So the next two, or the final two abatement webinars that are scheduled, as Jennifer said, will be on November 9th and on December 14th. And we kind of saved some of the best for last. On November 9th, we'll have a presentation from kind of a group of individuals in Abatement, Virginia, which is pretty far west in Virginia. They were able to launch a residential treatment center for women. But instead of having a not in my backyard reaction from the community, they had overwhelming support from the community. And the facility is right in the middle of a neighborhood, right close to downtown Abingdon. And everybody we talked to in the town just couldn't be happier about having this facility in place. And so what we asked for the folks to present about is, how did they do that? How do they generate that level of broad-based community support for a facility that a lot of times, you know, there's a little bit of that not in my backyard approach. And so the presenters we have lined up for that do a great job, and I think they have a fantastic story to tell. So we encourage folks to register for that one. And finally, our last session of the year is on December 14th, and it's an overview of the state's data warehouse, which is called the Framework for Addiction Analysis and Community Transformation. And it's a warehouse that localities and state agencies can report data to and receive customized reports. It's data, all things addiction related. Recently, the governor issued an executive order that requires the executive agencies that work within the addiction space to fully implement and use this data warehouse. And so it's an exciting opportunity to be able to participate in that. Of course, the things that get measured are the things that get improved. And so this is an opportunity to participate in that. And so we appreciate all the attendance that we've had over the course of the last several months, and hope that you folks can join us again for these last two sessions.
Okay, Monique, you covered everything so thoroughly that nobody has any questions. So clearly.
No comments, no questions. All right, I'll take that as a win. A win is a win.
You did have this comment. Amazing narrative.
Oh, well, thank you. That made me smile. Thanks.
All right. So thank you, everybody, for coming and participating. And we do appreciate your attendance. Thank you.